So I hope everybody knows this, like recently in this year, in the March 2021, after the WHO guidelines came for the treatment of DRTB, Indian, the NTEP, that is responsible for management, or I would say making the guidelines, released the guidelines for the management of DRTB, that is drug resistant TB in India in March 2021. So, but initially we'll be discussing the management of drug sensitive TB, then we'll go move on to the management of drug resistant TB. So, before moving on to the proper part, let's first importantly, we should understand which is clinically important as well as guideline, but it is very important. Okay. So, this is very basic microbiological part. So tuberculosis infection is the microbacterium tubercular bacilli enters our body for the first time. It produces an immune response, and in majority of the patient, it becomes latent. That is the infection becomes silent and leads to the latent TB infection. So per se, I would say tuberculosis infection is presence of immune response to the tuberculous bacilli without any clinical manifestation of the disease. There is no sign, no symptom, but patient is having the latent TB infection. So I hope you all know this. This is important, particularly for the tuberculosis preventive therapy. Like we won't be discussing that today, but this is very important for that thing. So this particular diagnosed based on the two tests. I hope you all know this. It is one is interferon gamma release assay, and second is the age-old Montauk's test. And the disease is whenever the patient is having signs and symptoms of disease of tuberculosis infection. It may be pulmonary or extrapulmonary tuberculosis. After this, it's very important to understand the difference between presumptive TB and clinically diagnosed TB. So presumptive TB is anybody who is having symptoms suggestive of tuberculosis. I hope everybody knows the four symptom complex of tuberculosis. Apart from that, we may have many other symptoms, but fever, cough, weight loss, and night sweats, these are the four classical symptoms of tuberculosis. Not just these four symptoms, but any patient who is having signs or symptoms which are suggestive of tuberculosis, but you have not yet diagnosed it microbiologically or using some investigation. So anybody who is a suspect, we call the patient as presumptive tuberculosis. Now, once obviously if we are suspecting a patient to be having tuberculosis, we will obviously be doing investigations. If in the investigation, if the patient turns out to be either smear or culture or any of the three, rapid diagnostic, I would say per se molecular test, if the patient turns out to be positive by any of this one, smear or culture or rapid diagnostic test, then we call it as microbiologically confirmed TB. But I hope you all know, and many would have experienced this situation, that there are so many cases, especially more so for extrapulmonary tuberculosis. Many times we have to diagnose tuberculosis just based on the symptoms, sign, and very importantly, other ancillary investigation. So I would say all smear, culture, and rapid test are negative here. But you have some ancillary investigations. When I say ancillary, we'll be discussing that in the upcoming slides. So you have some either X-ray evidence, some X-ray classical evidence, or you may have some CT evidence or MRI evidence, or perhaps some other test. We'll be discussing that in future upcoming slides. So if you diagnose the TB based on these ancillary investigations and the smear, culture, and rapid test all are negative, then you say the patient to be as clinically diagnosed tuberculosis. This is very important because whenever you have microbiological confirmation in those patients, it's like we are able to, I would say it's easy to diagnose or to differentiate the patient as having DRTB or DSTB. Secondly, for monitoring purpose also it helps. But so in practical situation, this is not always true. Many times we have to treat just based on the ancillary investigations. So when I say tuberculosis, disease, obviously a disease. It could be pulmonary or it could be extrapulmonary. So management wise, there is not much difference, I mean, with respect to the drugs, but to some parts there is difference in the presentation. So because pulmonary tuberculosis obviously is more common, is more infectious. APTB is having specific pattern and specific organ involvement. So pulmonary tuberculosis, just remember one thing, that miliary TB is obviously included in the pulmonary TB. Secondly, why it is important to know about EPTB? Because many of the patients will be having smear negative, culture negative, even the rapid test will be negative, and you may have to treat the patient based on the ancillary investigations. So some important common examples will be lymph node TB, pleural effusion, CNS TB, obviously in multiple ways the patient may present, spinal TB. So I think we will include spinal TB can be included in CNS TB only. Then you have pericardial involvement. Then you may have GI involvement in the form of intestinal tuberculosis or many times even ascites. So these are some of the common examples where you may get the EPTB. Commonly, everybody would have seen the patients of pleural effusion, pericardial effusion, tuberculous meningitis, or maybe tuberculoma, or even scrofulloderma, or many very commonly even GI involvement in the form of ascites or intestinal tuberculosis. So before we move on to the diagnosis, let's just understand some important terminology with respect to the resistant TB. So why I'm discussing, because earlier we used to have a bit different definitions, but now we have some different definitions. That's why I'm discussing this currently. So mono drug resistant TB is like very crude term. It's basically resistance to one of the first line drug. Even now, there is some difference between the first line drug and second line drugs. First line drug are drugs which are used for drug sensitive TB, and all the other drugs are basically the second line drug which are used for management of drug resistant TB. So it is any of, or for, I hope you all know the first line drugs are only now 4, H, R, E, and Z. So resistance to any one of the first line drug is considered as monodrug resistant TB. The subtype of this is INH resistant TB, in which you have resistance to only INH. Okay, you have resistance to only INH with, this is very important, INH resistance is there, but rifampicin is confirmed to be sensitive. Okay, I hope this is very clear. Rifampicin is sensitive either based on the culture or rapid methods, but there is INH resistance. If you add resistance to Z or E in this, then you call it as polydrug resistant TB. Okay, or PDRT. This is important because management of INH resistant TB and polydrug resistant TB without rifampicin resistance is completely different. Okay. Now, rifampicin resistance TB is basically resistance to rifampicin plus or minus. You may have resistance to other first line drugs, but there's for sure resistance to rifampicin. Now, MDR TB is rifampicin resistance plus INH resistance with or without resistance to other first line drug. Am I audible? Friends, am I audible?
Yes, sir, you're audible.
Yeah, thank you. So now comes the main difference. This is almost same as the earlier thing, but now you have something called as pre-XDR, and you have something, we already discussed this PDR-TB. You have something called as pre-XDR and XDR-TB. So before knowing this, I think you should be knowing one thing. We'll be discussing that in upcoming slides. Pre-XDR-TB is basically MDR-TB plus resistance to fluoroquinolones. Okay, I hope this is very clear. This is basically called as pre-XDR TB, and everybody knows only two fluoroquinolones are being used for management of tuberculosis, that is moxifloxacin and levofloxacin. So resistance to any of these agents with MDR-TB, that is called as pre-XDR-TB. Now comes the main thing. It is basically pre-XDR-TB plus, I hope you all know earlier the definition of XDR-TB was resistance to the second line injectable agent, but now this is out because now actually uh, when we'll be discussing in future slides that now we are like trying to like remove the all the injectable agents from the management of DR as well as DSTB. So XDR-TB is basically resistance to rifampicin, INH with fluoroquinolones with this is now very important, any category A agent. We'll be discussing what is category A drugs. Obviously, apart from fluoroquinolones, you have only two category A drugs, that is linezolid or bedaquiline. Okay, so you have linezolid or bedaquiline. So please remember this very important definition of XDR-TB. So MDR-TB plus resistance to fluoroquinolones plus resistance to either linezolid and or bedaquiline. Okay, so we'll be discussing this, what is category A, what is category B, category C drugs in the upcoming slides. Now, obviously this is a revision for majority of the people, like everybody knows this. Diagnosis of tuberculosis is obviously based on the microbiological diagnosis, and you have other investigations. So I was just discussing before that if you have smear positive or culture positive or rapid diagnostic test positive tuberculosis, you call that patient as microbiologically confirmed tuberculosis. And for patients in whom you have all these reports negative or it's not available, in that case, when you diagnose the tuberculosis based on the other investigations, then you call it as clinically diagnosed TB. So obviously this will depend definitely, no doubt, on the presentation of the patient, whether patient is having pulmonary tuberculosis or extrapulmonary tuberculosis. So obviously we should be understanding what will be the specimen we will be getting for diagnosis. For pulmonary, it is very straightforward. It will be mostly sputum, which may be induced or it may be spontaneous. Or second, it can be, this is very important, like we should try our best to get a microbiological diagnosis. So whenever this BAL is possible, you have the facilities for getting this, you should get it done. So either BAL or in pediatric age group, you may have gastric aspirated the sample. Okay. So these are the sample which you obtain for pulmonary tuberculosis. And obviously you have to perform smear microscopy. We'll be discussing, we have only two methods for smear microscopy. We'll be performing culture if required. And obviously nowadays, like upfront, we go for the rapid tests. That is CBNAT or TrueNAT. Okay. So for pulmonary samples, you can do this and any of these three. Now, for extrapulmonary tuberculosis, based on the site, you will be having different samples. Obviously, for TB meningitis, you will be having CSF. For lymph node TB, you will be having lymph node aspirate. It may be FNAC, it may be like in any form, mostly it is FNAC. Third, you may get the fluids. I hope you all know the fluids, obviously the pleural fluid. In case of suspected exudative pleural effusion, you may get the sample of pericardial fluid. You may get the sample of, I would say, ascitic fluid. And rarely, I would say very rarely joint fluid. So obviously joint TB is also a manifestation of tuberculosis. But so these are the fluid that you may get as a sample. Apart from this, what is the more important fourth sample? It is tissue. So I hope you all know when the FNAC is inconclusive, we are not able to get a clear-cut diagnosis, we go for the tissue-based diagnosis if possible. Say, for example, we do the thoracoscopy and get a pleural biopsy for a patient who is having suspected tubercular pleural effusion, which is not being proved by other techniques and other methods. We may even get the sample of lymph node biopsy, or for intestinal TB, we may get the sample of intestinal tissue. So tissue-based diagnosis, tissue-based sample. Okay. Now, very, very important thing I want to discuss, one important thing here, that rapid tests, that is CBNAT and TrueNAT, can be used only for 3 type of samples. Routinely, it can be used only for 3 samples, either the samples of that is pulmonary TB, it can be sputum or BAL. Second is CSF, and third is lymph node, or I would say like mostly it's lymph node aspirate. You may even sometime get a cold abscess, so without involvement of lymph nodes, but per se this is sufficient. So rapid test, that is CBNAT or TrueNAT, can be used only for these 3 samples. Please remember this thing. It is not recommended for use in pleural fluid, pericardial fluid, ascitic fluid, because sensitivity is very low. Obviously, specificity is good, but sensitivity is very, very low for the samples. So in general, as per the guidelines, only these 3 samples can be used upfront for I would say, for except EPTB, we upfront we go for CBNAT of these 3 samples, because smear is negative in majority of the patients. Okay, even not in guidelines, but if somebody asks you which fluid out of pericardial, pleural, and ascites is most likely to yield something on rapid or the smear, you have to say pericardial fluid, but not as per the guidelines. So you may occasionally want to use CBNAT for pericardial fluid for diagnosis of pericardial effusion caused by tuberculosis. Okay, so I hope this is very clear. When I say tissue-based sample, we'll be discussing in the upcoming slide. Now we have discussed the samples. Now we'll be discussing about the methods. So obviously, I'm not going to go into detail of the microbiological techniques of doing all these things, but we have 2 methods, that is ZN stain. Obviously, both are acid-fast staining methods. One is ZN stain, and second you have fluorescence, auramine rhodomine stain. Auramine fluorescent stain. Specificity is good for both, but slightly the fluorescent stain have slightly better sensitivity. But though I hope you all know that this is not the easily available method all over the India. It is time consuming. It is like main thing that is not much economical. So ZN stain is the most commonly used method for smear microscopy. The smear could be performed on sputum samples. It could be performed on the aspirate samples. It could be performed on any fluid also, though sensitivity for the fluids is very low. Now coming on to the culture-based methods. See, I am currently discussing based on what is there in the guideline, what is available in the public sector. Obviously, there will be some method which will be easily available in the private sector. So currently, I am discussing guidelines which are more so for the public sector. Okay, so culture-based methods, you have solid culture. Only one is used among this is LG, Lowenstein-Jensen medium. LG medium is the only solid culture method which is used routinely for diagnosis of tuberculosis. And more commonly, what is recommended, because I hope you all know solid culture method, it takes a lot of time, like they require 8 weeks, even more than that sometimes, for like growth of the tuberculosis. So nowadays you have the automated liquid culture. Automated liquid culture. What is being recommended and being done as per the guideline is Bactec MGIT 960. Okay. So this is based on obviously oxygen sensitivity. So like when the MTB bacilli grows, it like uses the oxygen, and there is some oxygen sensitive fluorescent marker which we use to like detect the growth of the bacteria in the culture. So this is the method which is recommended under the guidelines. Obviously, you have other liquid culture like Bacti Alert. You have even Versatric. So other methods are available in the private setup and other setups, but frequently in government setup, you have only this method among the liquid culture, that is Bactec MGIT 960. Now,
I hope you all know we are currently discussing the diagnosis of tuberculosis, not of the drug-resistant TB. For DRTB, I will be discussing separately. So, and the rapid diagnostic method which have been approved for use for diagnosis, I just told you we can use it only for sputum samples or BAL. We can use it for aspirate of fluid, lymph node usually, and third is CSF. These three are the samples in which we can perform this, and two tests are currently are available and being routinely used. That is, one is CBNAT, that is the gene expert. Second, you have TrueNat. Okay, so the obviously both are PCR based rapid techniques, but there is some slight difference between these two. So this will detect both the bacilli with resistance, and only obviously it can show only rifampicin resistance. So the result will be in this form: MTB detected, and it will show rifampicin sensitive, rifampicin intermediate, or rifampicin resistant. And any of this, the report will be in this form, or it will be MTB negative. And TrueNat is it is a sequential method. So initially you have to perform first test where you perform this test to detect MTB, and then you perform the test to detect rifampicin resistance. Okay, so this is the basic difference between these two. Not going into very much detailed technical parts of this, and that is not required for us as a clinician. So these are the methods which we can use for diagnosis. So first is smear, that is mostly Zn culture, mostly liquid-based methods, and the CBNet or TrueNet, whatever is available. So I just discussed with you that many times you may not have positive reports of any of these three, or many times this investigation are not available apart from Zn. So, or for example, say culture is taking so much time, say 2 weeks, 3 weeks, even liquid culture takes time. So many times you have to start treatment before without waiting for the reports of culture. So chest X-ray is the obviously most important investigation for pulmonary tuberculosis. Many times you go for CT chest or abdomen, or based on the local site, whatever you are suspecting. So chest X-ray, CT scan, and obviously MRI, very important for, yes, I hope you all know, CNS. So both spinal as well as the TB meningitis and tuberculoma. And CT head will give us clue for diagnosis, but for confirmed diagnosis of tuberculoma, TBM, spinal, it's better obtained by MRI. Okay. Then you have fluid analysis. So pleural fluid, you can have ascitic fluid, you can have pericardial fluid, you can have joint fluid. So obviously for pleural fluid, we have to go for the Light's criteria to diagnose exudative pleural effusion, and then we go for the ADA. So you have some specific findings suggestive of tuberculosis on pleural fluid, like for example, lymphocyte predominance, then exudative criteria by exudative picture by Light's criteria, and you have ADA. Now see, I'm not sticking to one value because various studies have shown different values of ADA having different sensitivity and specificity. But for practical purpose, I'm saying for ascitic fluid, for pleural fluid, the ADA value, I'm telling this is very variable. In various guidelines, this is variable and there is no single cutoff value. So based on your clinical picture, where you want to rule out or rule in tuberculosis, you may use a different cutoff. But in general, I would say for pleural fluid, it is 40. For ascitic, it is 40, and for this both it is 60. This is not just very single cutoff value. So you can these values may vary based on your clinical scenario, whether you want to rule in tuberculosis or whether you want to rule out tuberculosis. Okay, so okay, and obviously it has to be exudative picture in all these fluids. Then you have tissue diagnosis. For tissue diagnosis, I hope everybody knows smear. Obviously, we'll perform this smear, that is Zn stain, apart from the routine H&E stain. If it is positive, it's great, but many times it does not come positive. So we may want to look for other evidence on histopathology, like very important caseating necrosis and granuloma. Obviously, they are not specific, but in appropriate clinical scenario, in absence of any other evidence, you may use this evidence for confirmation, I would say, for diagnosing TB clinically and start treatment. Okay. So I hope now this is very clear. We have discussed till now the diagnosis part of the drug sensitive tuberculosis. Now, like this is just a simple algorithm for diagnosis of the pulmonary tuberculosis in patient that comes to you. So many years back, earlier it used to be like you get a smear, then you get a chest X-ray. Now it is like smear and chest X-ray guidelines came which suggested to use smear and chest X-ray. And now, like in many cases, especially in some areas, the guidelines are now recommending straightforward going for CBNAT, because CBNAT is having much better sensitivity as compared to the other smear and chest X-ray. Okay, so but this is still very useful. This is still very useful. Particularly CBNAT is directly used in cases of EPTB. I just told where you can use this in case of HIV in pediatric patients. Okay, in these populations, you may need to use CBNAT upfront. But obviously, if you have smear positive, it is like best evidence that you can get. So based on this algorithm, I'm not going to discuss this. This is very straightforward. You have either smear positive and chest suggestive of tuberculosis. In this scenario, just one thing you need to take care that if your patient is having high risk for drug-resistant TB, either rifampicin-resistant or MDR TB, you need to go for CBNAT even in those patients also before starting treatment. But if patient is not having any risk factors for drug-resistant TB, you can directly start treatment. Smear is positive, chest X-ray is not classical of tuberculosis. In that case also the same thing. But in the other scenario where you have chest X-ray suggestive of tuberculosis, but the smear is negative, CBNAT is recommended as a next investigation. And I just told you in the CBNAT you get the report in the form of rifampicin sensitive or indeterminate or resistance. Whenever you have rifampicin resistance, we'll be discussing how to manage those cases. But if you have rifampicin sensitivity, in absence of any drug resistant TB situations, we will directly treat the patient as the drug sensitive TB. But if you feel the patient, like say for example, if patient is a relapse patient, if patient is a defaulter, if patient is a patient who has got a recurrent TB or having contact with some drug DR TB patient, in that case you may go for CBNAT and other methods for diagnosis of drug resistance. Otherwise, in other patients, you can directly start treatment for DSTB in these patients. Okay. If you're getting the report in the form of rifampicin indeterminate, what we do is we again collect the sample and we send the CBNAT again. If second time it is again showing indeterminate, then you have to go for the next generation method. That is, after CBNAT, the next method that is available for use is LPA. We'll discuss that in upcoming slide. That is line probe assay, or the LPA is the genotypic method, and or liquid culture, which is a phenotypic method for detection of drug resistance TB. We'll be discussing in the upcoming slides. And in patients who is having, like simply, I would say, for example, this being one scenario, he's having fever for more than 2 weeks, just giving an example, and cough for more than 2 weeks, but you have some clear-cut alternative diagnosis. In that case, obviously, you won't be like doing the other investigation, and you may diagnose the patient as having other disease, not tuberculosis. You may treat the patient. But if you are still having high clinical suspicion, even after you have smear negative and check X-ray is not classical of TB, but based on some symptoms, you think this patient may have tuberculosis, you may even get a CBNAT done for that patient. Okay. Now, this is obviously a bit different from for extrapulmonary tuberculosis. I just told you many times you have to diagnose EPTB just based on the radiological investigations, because many times sample is not available. I'm just giving a classical example. A patient who is presenting with seizure and you get tuberculoma on CT or MRI. In that case, like, it is very impractical to get. I would, it like you can get sample, but it's very impractical for just getting the sample and doing a brain biopsy for the purpose of diagnosing tuberculosis is not practically done. So in that case, you may have to just rely on the MRI features or CT features and start treatment. But for some, you may get some sample. Say, for example, if you have a case of pericardial TB, you may get a sample for pericardial fluid. For lymph node TB, you may get a lymph node aspirate. In that way, so if appropriate specimen is available, in that case, I just told you, CBNAT can be done for the two samples I just told, lymph node aspirate and CSF. For other samples, like, it is not recommended as per the guideline because sensitivity is very low, but still, clinically speaking, practically speaking, we sometimes use, and occasionally we may get positive results. But main thing to remember, if we use for even per se lymph node aspirate, for CSF or other sample, CBNAT is not having very, very great sensitivity. Okay, so negative result
Ashraf, you're not able to hear you actually.
Hello. I'm not able to share the content. Yeah. Am I audible now?
Yeah, you're audible.
Yes, sir. You're audible, sir.
Yeah. Sorry for the interruption. So, yes, like, we'll start with this again. So for extrapulmonary tuberculosis, I just told you that many times you may not have sample available for the diagnosis, and in some case you may have the sample. I just told you earlier also, for CBNAT can be done as per the guidelines for either sputum or lymph node aspirate or the CSF. For other samples, you may use it like as per your discretion, but not recommended by guideline because of low sensitivity. And in case CBNet is not available and you are still suspicious of tuberculosis, you can get a liquid culture done, which is a rapid, I would say rapid as compared to the solid culture. And based on that, you can diagnose culture positive. If it's culture positive, it is great. But many times you don't get even culture positive, and if you have a high clinical suspicions, and based on the other ancillary evidence of tuberculosis, you can still start the treatment of tuberculosis. See this, I just told you this other diagnostic tool, that is either CT, X-ray, or you may be like any other fluid report. Based on that, you can start the treatment of tuberculosis. And obviously this is very like I hope you all know that for saying that patient is confirmed like I would have successfully treated for tuberculosis, you need conversion from positive to negative. But if patient is negative initially, you may have to use the other evidence like increase in the weight, like improvement in the appetite, increase in the weight. Patient like now patient was initially febrile, now has become afebrile. All those things you may have to use in patients in whom you have diagnosed TB clinically. If the symptoms are not resolving even after the initiation of treatment, you may think of either DRTB or you may have to think of some alternative diagnosis. Okay. Now, the diagnosis part is, I hope, clear. Before now moving on to the diagnosis of drug-resistant TB, we need to know this classification of anti-tubercular drugs which is currently used. So first line drug is, there are only 4: HREZ, that is INH, rifampicin, ethambutol, and pyrazinamide. Okay, friends. So you only these 4 drugs which are used for management of drug-sensitive TB, and all the other drugs are the second line drugs, or better you call it as nowadays as drugs for drug-resistant TB. So they have been classified now based on the WHO recommendation as this. This is the classification that we should follow for grouping the drugs. Okay, so group A, group B, and group C. So it is based on their efficacy. They have been classified. So group A is obviously having the maximum efficacy, group B less than that, and group C as compared to group A and group B, they have the least efficacy. Okay. So I was just discussing earlier when I was discussing the like definition of pre-XDR and XDR TB. In group A, you have 3 medications: bedaquiline, linezolid, and the fluoroquinolones. Only 2, either levoflox or moxifloxacin. In the group B, you have 2 drugs, that is clofazimine, and 5th is cycloserine or teracidone. Obviously, this is easily available, so we use this drug frequently. This table is very much useful, especially for management of drug-resistant tuberculosis. We'll be discussing that in the upcoming slides. And the group C. Now, please stress on this thing: 6, 7, 8, 9, 10, 11, 12. So you have only 7 drugs. Now, coming on, I want to discuss this as compared to earlier. What is the change? See, earlier, like in the previous DRTB guidelines, we also had amoxicillin plus clavulanic acid. We also had kanamycin. We also had capreomycin. We also had thiacetazone. But all those drugs are now not included in the management of drug-resistant tuberculosis because they are not being used. So out of this group C agents, if somebody asks you which one to select first of this, obviously the thing which has to come is delaminid. Whenever it is available and it can be used, delaminid is the first choice among the group C drugs. Okay. So we should use group A drugs and group B drugs, and if some of the drugs cannot be used because of resistance or intolerability, you may have to use the group C drug for management of DRTB. We'll be discuss how to use these drugs in the later slides. Okay. Now, I was earlier using the word phenotypic versus genotypic method. Yes. So what is phenotypic methods and what are genotypic methods? Basically, when we use the phenotypic method, we use the word called as drug sensitivity testing. That is drug sensitivity testing. But when we are detecting drug resistance by detecting the mutated product, then it is called as drug resistance or DRT, drug resistance testing. So by using specific mutated genes which are responsible for the mutation to a particular drug, we detect that mutated gene, and then we label the patient as having whatever drug resistant TB, either rifampicin or isoniazid or fluoroquinolones or aminoglycosides, whatever may be the case. So in that case, it is called as drug resistance testing, and here it is called as drug sensitivity testing. Okay, so for phenotypic methods, remember this thing: we do not have phenotypic methods available for all the drugs. For some drugs we don't have, for some drugs we don't perform because of some technical issues. So for which drugs it is available, we should be knowing this thing. I want to say that here only. Phenotypic methods, whether available or not, genotypic method available or not. This is very, very important, please. So you have phenotypic methods, that is culture based method available for both. Both methods are available, genotyping as well as phenotype. For bedaquiline, no genetic method is available. You have only phenotypic method. That too, it is not it was not available very recently, but now it will be available in near future. For linezolid, you have phenotypic method, but no genotypic method available. For clofazimine, it is still in the query stage, I would say. No genotypic method available. For cycloserine, no genotypic method available. It is still query. When I say query, it is still, I would say, it is not being routinely used for routine purposes. Okay. For ethambutol, you don't have any method available. No, not genotypic, neither phenotypic method available. Delaminid, it is still query. Pyrazinamide, yes, you have this phenotypic method available, but no genotypic method. For this, nothing is available. For this, you have, I would say, genotypic method is available. And to some extent, this is also available. But we frequently use genotypic method for detection of amic acid resistance. For ethonamide, you do not have any phenotypic methods, but yes, this is available for some resistance. And for this, nothing is available. So this is very, very important. Please understand this thing. Genotypic method is available only for, I will summarize this in later slides, but before that, let's discuss what are the methods available. When I say phenotypic method, it is obviously going to be culture based method. That is conventional drug typing or drug resistance typing that we use for other tissue, like other organisms. Okay, and what is recommended, I just told you earlier also, only liquid culture. Only liquid culture based methods, and most commonly used among them is Bactec MGIT. Okay, Bactec MGIT. So this is the method which is recommended for culture based or liquid culture based method. It is called as, in short, it is called as LCDST, liquid culture drug sensitivity testing. Okay, and see, this is very, I copied this statement from the guideline. So quality assured DST to rifampicin, isoniazid, pyrazinamide, moxiflox, levoflox, linezolid, amikacin, kanamycin, and capromycin are available. Let me just correct this thing, small thing. For this, yes, it is available. So it is available across the country routinely. For other, see, for bedaquiline, delaminid, and I just told you one more. For these two drugs, it will be available in short time. Even for clofazimine also, this will be available in short time. But for these drugs, I just told, cycloserine, imipenem, all these drugs, we don't have anything available. Okay, but for clofazimine, delaminid, bedaquiline, it will be available in near future. But for this, you have routinely available TST. Okay, I hope this is very clear. So this is the thing which, this is based on the 2021 guidelines. It says that it will be available in very short time. So for these drugs, you have DST available routinely. So levoflox, moxiflox, this will be available. Okay. Okay, I hope this is very clear. So for these drugs, DST will or is available for like detecting resistance to these agents. Okay. Now coming to the genotypic methods. Now, which methods are being routinely employed for detection of resistance? So obviously this is very clear. Gene expert or the CBNAT based method. This can detect resistance only to rifampicin. Okay. TrueNAT can detect resistance to only rifampicin. So these two methods are used for both diagnosis as well as detection of rifampicin resistance. And this is one test, Haynes genotype test, which is not available, not included in the guidelines, but it is available in the private sector. It is available for use. And what is the advantage of this test? This is like, I would say, PCR based rapid test, but advantage is it can both diagnose as just like CBNAT, but in addition, it can diagnose both INH resistance plus rifampicin resistance. Okay, I hope this is very clear. Haynes genotype test, which is available in the private sector, not included in the guide, not I would say not included in the public sector. This can be used for both diagnosis as well as for detection of resistance to INH and rifampicin. This is also obviously rapid diagnostic method for detection of resistance as well as for diagnosis. And this is the main test after the CBNAT and TrueNAT for other drugs. For other drugs, this test has to be used. Now remember, line probe assay is a PCR based method, but it's like compared to the CBNAT and TrueNAT, it is a bit more time consuming method. Having said that, I told you that genotypic method is available not for all drugs. It is available for only some of the drugs. Which drugs? We will see that. So first line LPA and you have second line LPA. Okay, first line and second line. We'll let you know why it is important. So first line LPA is for rifampicin and isoniazid. Okay, and second line is for fluoroquinolones. Obviously, we use only these two drugs, moxiflox and levoflox, and for the injectable agents. As injectable may be only amikacin. Obviously, other drugs also, but as per the guidelines, we use only these two drugs, amikacin and streptomycin. Okay. So first line LPA is for rifampicin and INH, and second line LPA is for fluoroquinolones and injectable agents. Now, I hope you all know what is the basic principle behind all this rapid test, that is LPA or Haynes test, or I would CBNAT or TrueNAT. The basic idea here is you detect the mutated gene. So I just told you, we only for this 4 group of drugs you have the genotypic methods available. Okay, this two constitute the first line LPA and this constitutes the second line LPA. Okay, so we have to remember this gene. For rifampicin, obviously RPOB is the name of the gene. For isoniazid, CAT gene, INHA. Why it is important? Because if patient is having, we'll discuss that in future slides. If patient is having resistance to both CAT-G and INHA, in that case, you cannot use the short regime. Do not use the short regime. We'll discuss what is this short regime. Secondly, if patient is having mutation to INHA, this means patient is resistant to ethionamide also. Ethionamide, prothionamide also. And just to say, INHA means low level resistance and CAT-G means high level resistance. This is because if the patient is having resistance to INHA, you can use high dose isoniazid. But this was like concept which was earlier used, but nowadays a resistance to any of the one agent you can use high dose isoniazid, and resistance to both you cannot use isoniazid at all. Okay, so you cannot use short regime. Now coming on to fluoroquinolones, you have two genes, GYRA and GYRB. For injectable agents, you have two genes, small RRS and EIS. So this is like we have to mug it up. We don't. If you want to like go into detail of the interpretation of these genes, you can like go through the guidelines. I have not included that part because of the lack of time. Okay, so remember this, only for this 4 group of drugs, I would say only for this 6 drugs: rifampicin, isoniazid, moxifloxacin, levofloxacin, amikacin and streptomycin, you have the genotypic method of DRTB available. Okay, so I hope this is very clear. Now, I hope like I'm very clear. If at all you have any doubt, you can definitely say on the YouTube live channel. So now coming on to the management of drug sensitive tuberculosis. This is very straightforward. You have 2 months, or better we say 8 weeks. This is the intensive phase of HREZ. HREZ based on the weight based. It has to be weight based. And you have 4 months, or better 16 weeks of HRE. Okay, only Z is removed. Earlier it used to be HR. No, just remember this simple straightforward thing. It is 8 weeks of HREZ and it is 16 weeks of HRE. Important thing to remember here is there is like now, not now, I would say 2 years back, there has been a change in the weight categories. I will discuss that. Earlier it used to be something different. Now it is a bit different. The category of weight has been changed from 2019. Okay. Duration will be discussed afterwards. In general, for majority of the tuberculosis, the standard guideline is to go for 6 months or 24 weeks. Okay. So this has to be remembered without any doubt. You cannot like skip this. You will have to know this without any doubt. This 25 to 34. It is like 2, 3, 4, 5. So it is very straightforward. What is this? Two tablets each of. So each FDC tablet, fixed drug combination tablet. So HREZ, you have 75, you have 150, 275, and 400. Okay. So each tablet, I would say each capsule of FDC of 4 drugs contains this 75 mg of isoniazid, 150 mg of rifampicin, 275 mg of ethambutol, and 400 mg of paracetamol. Okay, so just remember this dose and remember this categories 2, 3, 4, 5, 6. Okay. Now, for drug sensitive TB, monitoring of tuberculosis, I would say how do you monitor the patient? Obviously, the signs, symptoms, all those things should resolve. But with respect to the microbiological evidence, what is recommended is, obviously these all things include monitoring of LFT and CBC if required in certain patients. This is in addition to that. So for microbiological confirmation of confirmed patient has been treated as TB, what you have to do is at the end of intensive phase, you get a smear or whatever earlier was positive, smear or culture. In general, smear is done. Now, even if smear comes positive, you should not extend the duration of intensive phase by 1 month. But what is recommended is, if smear is positive by the end of, if smear is positive by the end of 2 months, what you do is you go for the, if you haven't done earlier, you go for the CBNAT or basically you go for the DRT or DST testing for drug resistance in these patients. You don't change the treatment, or you don't, I would say, you don't extend the intensive phase. You have to shift to the continuation phase of 4 months. But at the same time, you have to get this done, DRT or drug sensitivity testing, whatever is available for the detection of resistance. Okay. So I hope this is very clear. And at the end of continuation phase, if the smear is positive, then obviously this is treatment failure, and you have to look for, without any doubt, you have to strictly go for the testing of drug resistance, DRT or DST. You have to go for it. Okay. So in general, what is recommended is to get a smear at the end of 2 months of treatment or at the end of intensive phase. If it is negative, if like irrespective of it being positive or negative, you shift to continuation phase, but you have to get a drug resistant testing done at that point of time. And if it is resistant to some drugs, you have to modify the treatment based on the resistance, whether it is ionized resistant or something different. And at the end of 6 months, if smear is positive, then obviously smear, it is not just smear, I would say it can be CB-net also. Okay, it is not just smear. If it is positive, you label the patient as having treatment failure, and you have to look for DRT and DST. Okay, now role of steroids. Remember, as per the index TB guidelines, there are only 2 indications of steroids. Okay, 2 indication of steroids, no more than that. First is tuberculosis meningitis. Okay, and second is pericardial TB. Okay, pericardial TB. So only these 2 are the, I would say, evidence-based indications of giving steroids. Usually DEXA is used. You can use prednisolone also. Okay, and DEXA or prednisolone is used. The minimum duration in TB is 4 weeks, and over the period of 6 to 8 weeks, you gradually taper and then stop. For pericardial TB, there is no such specific guideline, but it is same like 4 to 8 weeks. Okay, so I hope this is very clear. Only 2 indication of giving steroids: tuberculosis meningitis and pericardial TB. Now remember, pericardial TB, in that also specifically in HIV negative patients. In HIV positive, like it's associated with more poor outcomes, so it is not recommended for patients having HIV positive and pericardial TB. For TBM, there is nothing like that HIV positive negative. For both, you have to use because it is having benefit. Now, duration of treatment, I just told you it is 6 months for majority, except for TB meningitis, it is 9 months. It is 9 months for TB meningitis. And see, this is very important to understand. For disseminated, for skeletal TB, you may extend the treatment up to, I would say, 9 to 12 months. Maximum 12 months. After 12 months, it is not recommended in general. Till 9 months, it can be easily done in case by case, in individual cases. For even 12 months, you have to like get an opinion of expert in this field to extend the treatment up till 12 months. But for TBM, it is 9 months. For routinely, for all other patient is 6 months. And for disseminated or skeletal TB, you may need to extend till 9 or 12 months. Okay, so this is very clear. Now for pregnancy, remember there is no change because we are not using streptomycin for drug sensitive TB. Now I want to make one thing clear. For both, this treatment is for both previously treated, obviously it has to be successfully treated, or newly diagnosed. For both, the treatment is same, but you have to be a bit more careful in patients who have been previously treated because there are high chance of resistance. So you should go for testing of DRT or DST in this patient for detection of resistance. But otherwise, treatment remains same initially for both these groups, and duration is also same. Earlier, it used to be like we have to give 3 months of intensive phase, 5 months of extensive phase, continuation phase, and then we have to like change the drugs. For first 2 months you have to do streptomycin, for next 1 month you use 4 drugs, for next 5 months you use 3 drugs. This is not done nowadays. It is very straightforward. Streptomycin is having no use for management of drug sensitive TB. It is used in only specific scenario where you have intolerance to some drugs. For example, it's like you may want to use this drugs if patient has developed some, I would say, drug induced hepatotoxicity, or induced hepatitis. If patient has developed, in that case you may use streptomycin. Otherwise, does not have a role upfront for management of DSTB. Okay, now for pregnancy, no change. So same treatment, same duration. Okay, no requirement of MTP, no like I would say no modification required for pregnant as well as the patients who are lactating. For liver disease, like I can't discuss everything in detail currently, but in general, I would say any patient who is having active liver disease. So in that case, if the ALT is 3 times upper limit of normal, you can consider starting the same drugs. But I hope this is very individual and in detail. You have to like assess the patient's scenario. It is not like one thing for all. It is variable from disease to disease. So this is very general guideline for less than, if it is less than 3 times upper limit of normal, ALT is there and no other contraindication, you can still go for the same treatment, but you have to be very much more careful in these patients. If it is more than 3 times upper limit of normal, you have to modify the treatment. Second thing, if it is patient is having decompensated liver disease, by this I mean CTP, B or C, the hepatotoxic drug should be avoided. Drugs not to be used. Okay, I hope this is very clear. So and for patients in whom you want to modify the treatment, like there are multiple options available here also. Some will say that no hepatotoxic drug I want to use in a particular patient. In that case, you go for LES. I hope you all know this: levofloxacin, ethambutol, and streptomycin. If you want to use one hepatotoxic drug, you can go for that also. This duration is 9 to 12 months. 9 to 12 months. Okay. If you want to use only one hepatotoxic drug, in that way, like you want to just use isoniazid or rifampicin. So basically, you have modification available for the individual patients. So you can either go for 9 months of, I'm just giving an example. You can go for 9 months of only these 3 drugs, removing the most hepatotoxic drug, that is Z. You can remove the Z and you can use this 9 months of HRE in these patients, or you can even go for 2 months of HRSE, followed by that 7 months of H and R. So like it is, I just told you, it is very individual. You have multiple options for this and you can refer to the guideline for like in detail discussion of this thing. I'm just giving some hint about how to go for it. So if you think the patient is not having actually very significant active liver disease, you may continue the same drugs, or if you think these drugs will be causing more harm than benefit, then you can decide on not using any hepatotoxic drug or using 1 or 2 of the hepatotoxic drug. Obviously, the duration of the treatment will change, but that you have to take care. Okay. Now coming to how do you modify the treatment in patients who are known case of CKD. Now for these patients, remember, for out of these 4 drugs, H, R, E, Z, the 2 drugs will require modification of dose. So ethambutol and parazinamide, the dose is same, you just make it thrice weekly. It is as simple as that. Okay. So thrice weekly. Initially, you are giving like OD dose once a day. Now it changes to thrice weekly, only for those who are having eGFR less than 30 or on hemodialysis. Okay. For more than 30, you don't need any change in the dose of the drugs. For less than 30 eGFR or patient who are on hemodialysis, for those patients, only change is required for ethambutol and parazinamide. Okay. Now, just very in brief about the main ADRs of the commonly used drugs. So I hope you all know isoniazid. Peripheral neuropathy is very common if you are not supplementing with pyridoxine. Pyridoxine has to be given. Okay. Skin rash can occur with any of the 4 drugs. Hepatitis can occur with any of the drugs except ethambutol. And specifically talking about GI symptoms are common with rifampicin. Hepatitis, obviously, it can occur with this. Curious reactions can occur with all. This is also very important. ITP is a known complication or known ADR of rifampicin. These are obviously typical, but they're uncommon ADR. I would say uncommon. For pyrazinamide, these 2 are very, very important. Though this is common, but this is not very significant for changing the management. For arthralgia, you have to look for uric acid and then to manage based on the whether the uric acid raised or it is not raised. Okay. And hepatitis, obviously you have to stop this drug. So basically this is the, I would say, just you can see, look at the main ADRs and uncommon ADRs. Okay. So arthralgia can occur with both. If somebody asks you which are the drugs which can cause arthralgia among the drugs sensitive TB, it is HREZ. Most commonly it is pyrazinamide, followed by that isoniazid, followed by that it is ethambutol. Okay, ethambutol is least likely to cause. Main concern of ethambutol, I hope everybody knows, is it is retrobulbar neuritis, the eye toxicity. Okay, so in children less than 5 years, in general, ethambutol is not recommended. Okay, so I hope this is very clear. Now let's discuss very important thing: management of drug-resistant tuberculosis. I hope now you are well versed with what is basically first line LPA, what is LCDST, what is second line LPA, what is RRTB, what is MDRTB, pre-XDR, XDRTB. So I would say that before this, based on the 2021 guidelines, it has to be either of these two regimens. Okay, I'm particularly for RR and DRTB or XDR, pre-XDRTB. We'll discuss like when to use what. Either it is going to be short course oral or it's going to be long course regimen. Okay, at present what we are using in place of this short course oral is short course injectable. But I have told you about our plan from this year is to shift from the injectable agent to the all oral agents, short course injectable. Okay, when I say short course, it is 9 to 11 months, and when I say long course, it is 18 to 20 months usually. Okay, so it is like earlier we used to have like very straightforward guidance. If it is RRTB, give this; MDRTB, give this; XRTB, give this. But now it is not like that. You have to see for other features and in resistance to other drugs. Then you decide the management of the patient. So this is just like in short about how do you go about the management of drug-resistant TB for diagnosis as well as management. So what I was telling this thing. So for all TB patients, like it has been started as a pilot thing for some areas. It is allowed to do CBNAT for all patients, positive, negative, key population, extrapulmonary, pulmonary. For all patients, you go for a CBNAT testing. But though it is not always practical or not always possible, but you should always ideally do. Okay. Now, all presumptive TB, you know what is presumptive TB and key population. When I say key population, it means those who are having high risk of resistance or you are having very low sensitivity to smear TB, like PLHIV, like pediatric age group. Okay, like I would say malnourished, but better to use word immunocompromised. So these patients are an EPTB. These patients are having high risk of getting resistant TB. That's why we go for the testing of CBNAT upfront, CBNAT or TrueNAT upfront. Or third this thing is this: when you have diagnosed the patient as drug sensitive TB initially and they are not responding as per they should respond, then you can still consider doing NAT in those patients to detect the resistance. Okay. Now, if rifampicin resistance is detected, okay, in that case you have to further do what I was telling. This first line LPA, second line LPA. First line LPA is for, yes, I hope you all know now, it is for H and R. Second line LPA is for fluoroquinolones and injectable agents. LCDST is for other agents, that is this. Okay. Okay, for this agents, you have to go for LCDST. And now, based on these results, we'll decide on what treatment the patient should be receiving. Should it be short oral course or it should be long oral course. Now, before going on to the RRTB, let's in short discuss about this. INH resistant. So what I was discussing, MRTB, that is monodrug resistant TB. INH resistant TB, and what is PDR or PDR TB is INH plus either E or Z, but not R among the first line. So it is very straightforward. So if you have a TB which is sensitive to rifampicin, it has to be confirmed. Rifampicin sensitivity is there without any doubt, but there is INH resistance in addition with or without resistant to ethambutol and paracetamide, in that case, you have to use this. This is the basic regimen. We have to modify this based on the results, resistant results. So it is levofloxacin, rifampicin, ethambutol, and paracetamide. For now, this is like this you may change 6 to 9 months. 6 months it's compulsory. You repeat the test, that is CBNAT, you or smear, whatever, or culture you repeat. And if it is positive, not actually at 6 months, you actually go for at 4 and 5 months. At the end of 4th and 5 months, you do this test to look for clearance. That is, if the culture or the CBNAT has become negative, you can stop the treatment at 6 months. But if it is positive at the end of 4th or at the end of 5th month, you have to extend treatment till 7th, 8th, or 9th month based on the results. Okay. So, but if it is positive at the end of even 8 month, 9 month, then obviously it is treatment failure. Okay. So at the end of 4 months, you send one sample. At the end of 5 months, you send one sample. If the sample comes positive at the end of 4th month for the organism, you may have to extend the treatment for one further month. If it comes positive at the end of 5 months, you may have to extend for one more month. And at the end of 6 months, if it comes at the end of 6 months, it comes negative, positive, then obviously you have to think of further resistance testing. Okay. Or patient may have developed resistance during the treatment also. So I hope this is very straightforward. Now, this is the modification in this. Say, for example, if levofloxacin cannot be used, if levoflox cannot be used, it may be because of the resistance, where levoflox is resistance, but moxifloxacin is sensitive based on the second line LPA. So in that case, obviously you can replace levoflox with moxiflox. Say, for example, if paracetamide cannot be used due to resistance or due to some intolerable side effects or whatever it may be the reason, you have to replace with linezolid. This is very important. Because it is a group A agent. I just told you to always prefer the group A agent, then group B, and then group C. Okay. Now, say for example, if linezolid can also not be given because of non-availability or some contraindication, then obviously what you have to do is you have to replace it with 2 drugs, because linezolid is a very potent drug, and clofazimine plus cycloserine will be like it will be equivalent to that. Now, if both resistant to both is detected, in that case, you can replace this with these 2 drugs, linezolid from group A and clofazimine from group B. Okay. And this is obviously no point discussing, because if it is R resistant, then you have to completely change your management, which we'll be discussing now. Now, how do you manage rifampicin resistant TB? So this I was discussing here. See, if you have rifampicin resistance, then you decide on if there is any additional resistance to some other drugs. So let me make it very simple, not making it complicated. So you have a patient who is having rifampicin resistance plus he is having INH resistance. But remember, you have the patient who is having either CAT-G or INHA. This is or is very important. It is not and. Or is very important. So rifampicin resistance plus INH resistance either to CAT-G mutation or INHA mutation, not both. And fluoroquinolone sensitive has to be confirmed. Okay, and there are some more criteria where you don't want to use this short course regimen. In this scenario, you can use this short course oral bedaquiline containing regime. Okay, so what is this short course oral regimen? It is obviously of 9 to 11 months. I just told you it is basically 5 months of continuation phase are fixed, but 4 to 6 months off. Now, what drugs to use? This is very straightforward. Okay, I just told you it is going to be bedaquiline. It's going to be bedaquiline plus levofloxacin plus ethambutol plus paracetamide. Okay, plus you have clofazimine, plus you have cycloserine, and you have high dose isoniazid. So you have this 7 drugs which you just a minute. So this is very important. It is not ethionamide. Okay, so you have bedaquiline, levofloxacin, ethambutol, parazinamide, clofazimine, ethambutol, and high dose isoniazid. This HH is basically high dose isoniazid. Okay, this is for 4 to 6 months. Okay, now it is very important to discuss this thing here. Why I'm saying this 4 to 6 months. So for bedaquiline, it is fixed. It has to be used for 6 months, no doubt about it. For other intensive phase agents, that is for other intensive phase agents, what you do is obviously for the CP, you have to use levofloxacin, you have to use ethambutol, you have to use parazinamide, and you have to use clofazimine. Okay, these 4 drugs are to be used for the 5 months. The rest of the drug, that is high dose isoniazid, ethionamide, these 2 drugs you may have to decide based on the smear or the CBNAT result at the end of 3 to 4 months of treatment. If it comes positive, you may have to extend the treatment for 2 months. If it has come negative, you can stop giving this agent and shift to these 4 drugs. So having said that, for 6 months, bedaquiline is compulsory. For the next 2 months, these 2 agents, that is high dose isoniazid and ethionamide, you may need to use based on your results of smear or the CBNAT or whatever test you are doing. And the last 5 months has to be these 4 drugs. Okay, I hope there is no doubt about this. Okay. If at all anybody is having any doubt, please click comment in the YouTube channel.
It's clear, Ashraf.
Okay. So I hope this is what this is very clear about the short course oral regimen containing bedaquiline. Everybody knows bedaquiline has been a game changer drug for management of drug-resistant tuberculosis. So because of bedaquiline, it has been possible to bring down the duration of treatment from 18 to 24 months to 9 to 11 months. But I just told you when you can use. Now this is very important. Where you should use this regimen. This is very clear. This is very clear. I just told you either INH or CATG, not both. This is also very clear. I just told you no resistant to fluoroquinolones. And it is not recommended for less than 5 years. Not recommended. Okay, above 5 years to 18 years, you can still use after consultation with pediatrician, but less than 5, it is not recommended. Now, very important. Now, there can be a scenario which is very common, which is going to be very common, where you may not have DST available for the levofloxacin routinely. I would say LPA is not available for levofloxacin, but still you want to use. So in that case, what you can do initially is you can just based on the so if there is no history of exposure to any of this medication which we are going to use in this regimen for more than a month, if patient has been exposed to any of these 4 agents for more than a month, you cannot use this regimen without any doubt. In that case, if you want to use, you need to have a result of resistance, either liquid culture DST or LPA, and which shows that it is the organism is sensitive to this drugs, and then only you can use. Now this is very important. These 3 are very important. Patient should not be having extensive TB. Patient should not be having any severe extrapulmonary TB. It's obviously based on the clinical judgment. And this is not for pregnant or lactating, without any doubt. We'll be discussing what modification we have to do for pregnant patients afterwards. But in general, it is 32 weeks. Okay, less 32 weeks. Pregnant for less 32 weeks, you cannot use this regimen. Okay, you have to get an MTP without any doubt. If patient does not give consent to MTP, you have to change the regimen, or you should not start this regimen. Okay, So I hope all these things should be met. Then only you can start this short course regimen of 9 to 11 months. Okay. Now, what is being currently used? I mean, it was being used. Gradually, it will be like phased out, like any with inclusion of the pedaclin containing regimen. So it is very simple. Say, what we were using, where we were using bedaquiline in oral course. What we are using here, we are using either amikacin or capreomycin or kanamycin, plus in place of levofloxacin, moxiflox is used, that is high dose moxifloxacin. Other drugs remain same. Okay, Z plus E plus ethionamide plus high dose isoniazid plus you have fluoxamine. So all the rest of the drugs remain same. Before the approval of this short course bedaquiline containing regimen, this regimen we are using, and we were using, I would say. Gradually this will be like thrown out of the course, but in this case the criteria remains same. Patient has to be proven sensitive to this second line injectable agent. It has to be sensitive to moxifloxacin. There should not be resistance to both CAT-G and INH. Then only you can use this regimen. Okay, the basic things remain the same. Obviously pregnancy may you cannot use this regimen, so that way it remains same. But main disadvantage of this regimen was the compliance, and I hope you all know one of the main drugs in this, I would say, considered to be main drug were the injectable agent. If they are not being used, then the success rate falls. That's why we have the very highly effective short course regimen, highly effective in those who are sensitive. That is, no resistant to fluoroquinolones, no resistant to no exposure to the agents which are being used for more than a month. Okay. So now the main thing, the long course regimen. Now this is like now very practical thing. We have this table in front of us. How do you make your own regimen of drug resistant TB? In this, remember, there is nothing like IP and CP. It is 18 to 20 months of treatment. No IP, no CP. So for all patients who are not eligible for the short course or oral or injectable regimen, for all those cases, you have to use this regimen. Okay, and this is a regimen, basically this is tailor-made regimen. You modify the regimen based on the patient's culture results, based on the patient LCDST, LPA results, and then you modify when give the treatment. But the basic regimen will be this 5 drugs. Okay, this is the basic regimen, as simple as that. This is the basic regimen. All the 3 drugs, one or both. It is always both drugs. So the standard regimen is going to be this. Okay, out of this, everybody knows this thing. This is only for 6 months. After that, you continue this 4 agents. Bedaquiline is not used for more than 6 months. Okay. Otherwise, for all the other agents, used for 18 to 20 months in general. So in patients who are having confirmed sensitivity to fluoroquinolones, who did not have any exposure to the other agents previously for more than a month, and where you cannot use the short course regimen, in those patients you have to use this regimen. Obviously this contains less drugs, but it is for more duration, 18 to 20 months. Okay, I hope this is very clear. So all these 3 agents and this 2, clofazimine, cycloserine, linezolid, bedaquiline, either of this, mostly we go for levoflox, but based on the resistance testing, you can modify either levoflox or moxiflox. Otherwise, you start with levoflox. These are the 5 agents you have to use. Now, based on the patient's status, say for example, you have the report of LCDST in front of you or LP in front of you, which is showing resistance to this drug. So both fluoroquinolones are resistant. So you are left with 4 drugs. Now, the basic rule for the management of or making this regimen is 5 drugs. So basic rule is 5 drugs has to be there. But remember, the grouping of these drugs is based on their efficacy. So group A is having maximum efficacy, followed by that group B, followed by that you have the efficacy of group C. So as the number of drugs from the group A and group B decreases, the efficacy of the regimen decreases without any doubt. But having said that, many times you do not have option. You cannot use these drugs. So for example, if patient is having resistance to levoflox or moxiflox both, you cannot use use this drug, there's no point using. So you use this 4 drugs plus delaminid. I just told you earlier that among the group C drugs, you have to prefer delaminid out of all this. Okay, because it is relatively more efficacious, chance of resistance are very low, and ADRs are also a bit low. And main thing, it's an oral drug. Okay, so I hope you all know there is nowhere there is pritomanid here. Okay, please don't ever say pritomanid here. Your BPAL regimen is completely different. Obviously, WHO has recommended gradually in India also you may get this regimen, BPAL regimen, bedaquiline, pritomanid, and linezolid in the future. But currently, it is not included in the group C drug. Pritomanid is a very efficacious drug for resistant tuberculosis, having more than 90% efficacy. But let's not discuss that currently. So let's take one more scenario. Say, for example, if patient is having pancytopenia, in that case, you cannot use linezolid due to any reason. You cannot use linezolid initially. You cannot use levofloxacin because of resistance. So 2 drugs now have been out of 5 drugs. So what you will do, you will add 2 drugs from the group C regimen. So for patient, I'm just giving one example. If patient is having fluoroquinolone resistance and patient is having, say, bone marrow suppression is already there because of any reason, so linezolid contraindicated. In that case, you have to change the regimen. Now what you are left with? You are left with clofazimine. You are left with bedaquiline. You are left with cycloserine. Now you have to add 2 more agents from group C, delaminid plus. Now it is like based on the patient, you can use any of this based on the sensitivity results. Say, for example, if your sensitivity testing says pyrazinamide is sensitive, you can definitely use pyrazinamide. Okay, or it is obviously individualized. If patient is having some contraindication to a particular drug, you will not use it. If you think that this patient is not fit for a particular drug, you will not use. So it's a tailor-made regimen, individual patient-based regimen. But the basic funda is very clear. Basic regimen should be all 5 group A and group B if not contraindicated, if there is no resistance to this agent. Otherwise, if some resistance is there, or if you have some contraindication for the use of this drug, for example, this is very important for bedaquiline. If patient is having QTC, especially F, for more than 500 seconds, and that is not acute, that is like even after correction of the correctable causes, like electrolyte disorders, if you correct those things even after that, it remains more than 500 milliseconds, you cannot use bedaquiline. Any patient having QTCF more than 500 and uncorrected, I would say get uncorrected arrhythmia, in those patients you cannot use this agents. For 450 and 500, it is based on the uncorrected arrhythmia. If the patient is having well-controlled arrhythmia, and if it is less than 500 but above 450, you can still consider using it after consultation with cardiologist. So I hope you all know bedaquiline, the main concern or the main ADR is the cardiac ADRs. Okay. So I hope this is very much clear. Now let's just discuss in short about the special situations. Especially most important is pregnancy. What you will do if a pregnant patient is diagnosed with drug-resistant tuberculosis. Okay. So say if it is less than 20 weeks of pregnancy, you have no other option. You have to advise MTP. If MTP is done, it is great, and patient can start on short oral bedaquiline if all other criteria are met. For patients who are more than 20 weeks and patient is unwilling for MTP, if patient is, I just told one thing earlier, 32 weeks is the cutoff for not using short course oral regimen. But less than 32 weeks, you have to continue you start or continue the long regimen that we just discussed currently. Okay, not the short course regimen. If it is more than 32 weeks, you can still consider using. After consultation with the obstetrician gynecologist, you can still you can consider using the short course oral bedaquiline containing regimen. Okay, I hope this is very, very clear. And obviously, from this drug, you will not like to use some drugs which are contraindicated in pregnancy. Say, for example, you will not use this drug in pregnancy. Okay, so you make a regimen based on the individual patient. Okay, so for example, CKD, it is like I just told you, you have to modify the dose of some drugs. Modify the dose of some drugs. Like, for example, you have to modify the dose of cycloserine, you have to modify the dose of amikacin, you have to modify the dose of parazinamide, ethambutol. So you have to modify the dose of the patient, especially EGFR less than 30. Okay, in advanced CKD, the bedaquiline does not require any dose modification, but in advanced CKD, it has not been studied. So you may have to be more cautious in those patients, because in advanced CKD patient, I would say patient on hemodialysis, it has not been studied, and bedaquiline has not been studied. So no recommendation is made for dose change in patient with advanced CKD. Okay, but for other drugs, this is very straightforward. For you have to change the dose of this drug, you have to change the dose of fluoroquinolones, have to make it half alternate day. Cycloserine has to be dose modified without any doubt. Ethambutol dose modification has to be done. Paracetamol has to be done. This obviously has to be done. No modification is required for this. Okay, no modification for ethanamide, protonamide, and this also you have to modify the dose. Okay, for CKD. Okay, so in patients with CKD, fluoroquinolones require dose modification. Bedaquiline in general does not require, but it is, I just told you, it is not studied in advanced patients. Linezolid does not require. Clofazimine does not require. Cycloserine, yes, it requires dose modification. Ethambutol requires. This is query. It's a new drug. Parazinamide requires. This requires change. This requires change. This does not require. This requires change. So among the CKD patients, this all things require modification of treatment. And for I just told you, in patient with pre-existing liver disease, it like basic principle remains the same. You have to, like, if patient is not having some active disease, or if patient is not having decompensated liver disease, you can still consider using all these drugs. Now among these drugs, linezolid, bedaquiline is hepatotoxic, linezolid hepatotoxic, fluoroquinolones are hepatotoxic, clofazimine is not, in general not, paracetamol is hepatotoxic, and ethanamide is hepatotoxic drug. Okay, among these drugs. So tailor-made regimen has to be made for those patients based on the patient's condition. If there is some absolute contraindication, you will not like to use these agents. Okay. So this was all for today. I hope you like this. If at all there is any doubt, you can definitely give your doubts in this chat section. I will definitely try to address the issues, address your doubts, whatever I can. And so this was my first lecture on this channel. I'm very grateful to Dr. Vijay for giving me opportunity. I've planned for taking further lectures at least once a week, especially based on the guideline-based management of other diseases, common diseases which we routinely see. So definitely some inputs from your side are welcome from you. So thank you all. Yes, Dr. Vijay.
Yeah, thank you, Ashraf. I think it was a comprehensive summary of what is really required, at least to get an idea of how exactly the management of both sensitive and resistant TB happens. Could you just add a few words on latent TB, like when should we treat, when should we not treat? I think controversy always is existing.
Sure. Now this is very you have made a point on this. Now we'll discuss that very straightforwardly. So now we have there is no confusion about this now. Okay, there is no confusion about this at present for something called as TPT, tuberculosis preventive therapy. Okay, there is no doubt about this, because you have July 2021 guidelines for specifically it's only addressing this thing, TB preventive therapy by NTEP. This is the latest guideline, I would say, which has been given by the NTEP. So what it says is, so what does it say? So all patients whom we should consider. So first, most important patients are HIV positive patients, irrespective of age. So one exception is that less than 1 year you may want to avoid, but that is not an absolute contraindication. So all HIV positive patients. Second, all households contacts children less than 5 years. Okay. And third, all other patients, all other with IgRA or Montux positive. So I hope this is very clear. So these are the three primary group of our interest. So first is all HIV positive patient. Second is household contact. Like you can go through the specific definition of what is household contact in children less than 5 years, irrespective of IGRA or Montauk's results, and all other with positive IGRA or Montauk. These are the three main, I would say, target audience for TB preventive therapy. And obviously, different drugs for TB preventive therapy with respect to, I would say, with respect to drug sensitive TB and drug resistant TB. So in that scenario, in that case, what we usually do is, first thing is always to rule out, to find the page. Okay. See, what we do usually is, first rule out, this is very simple, rule out active tuberculosis. This is very logical. Once the active tuberculosis has been ruled out, then for all these 5 population, HIV positive patients, age less than 5 years with household contact with confirmed positive patients, and third is all other patients with positive IGRA or positive tuberculosis, positive Montauk's test. So once you have ruled out, you have 2 options. Okay, you have 2 options. First is I would say better in terms of patient acceptance is the rifampicin plus isoniazid containing regimen. Okay, this is called as HR regimen. Okay, it is not rifampicin, it is rifampicin. Okay, rifampicin plus isoniazid, and it has to be given only 12 dose. Only 12 dose once a week. Only 12 dose, that is once a week for 3 months. So 12 dose means it is 3 months. This is the duration. It is, sorry, so not 12, it is 16 dose. It is 4 months. 4 months of rifampicin plus isoniazid, or second option is isoniazid alone. So the dose is very simple. Less than 10 years, you use 10 mg per kg. For more than 10 years, you use 5 mg per kg. Okay, and this is for 6 months. Okay, friends. So this is basically for those with drug sensitive TB. So once this is obviously going to be having a better efficacy wise. This, I would say, this combined regimen is slightly better than isoniazid alone. Secondly, acceptance wise, also this first regimen is better. Rifampicin plus isoniazid once a week for 4 months. That is 16 dose. And for drug resistant TB, it is a bit challenging on those cases. In that case, you have to look for whether it is fluoroquine sensitive and rifampicin resistant, and if it is rifampicin sensitive TB, and obviously INH resistant. That's why we are not using INH. In that case, you can use rifampicin, and here, if fluoroquine sensitivity is confirmed, see, it's but obvious that it is not for the patient, it is for the DRTB. Primarily we use for patient who are household contacts, direct contact with DRTB confirmed patients. Obviously for those only we will use. For others, we won't be using this regimen. For any patient who is having contact with a drug resistant confirmed tuberculosis, in those patients you will use this regimen. So if it is fluoroquine sensitive and rifampicin resistant, will use levofloxacin. But like, see, what I feel is it is like very much for the patient. Patient does not easily accept this regimens. It is not very like, I would say, with respect to the acceptability, levofloxacin every day is not very practical. And you can use rifampicin for patients who are having confirmed rifampicin sensitive but INH resistant TB. So that's all about. This is very summary. This is very small summary of the whole guidelines of 2021 about TB preventive therapy. Okay. So I hope this is very clear.
Yeah, I think this is a very important point that you mentioned. Because until that, there is always a controversy what to do if Monto comes indeterminate or it comes positive. So should you treat, should you not treat? So all those controversies are there. I think this guideline put everything to
yeah, exactly,
give more clarity to that. Yeah. I think one doubt is there. If patient is taking INH without B6 and he comes after 2 months with neuropathy, is it reversible?
Now, this is like, I would say it can be reversible. It can be reversible also. But the thing is, those you use for those patients who have developed neuropathy or complaints of peripheral neuropathy because of INH, the dose has to be very high. It has to be 100 to 200 mg per day of of pyridoxine for those patients. It can have some irreversible changes for after even complete treatment, but fairly, I would say it is reversible.
And there is one more question. Okay, why ethambutol causes optic neuritis?
Mechanism even I will have to see.
Okay, and one more question was PDR has resistance to INH and pyrazinamide or ethambutol, but still the management in the guidelines include both the same. Can you explain?
No. I just told na. See, this was the regimen for PDR-TB. Okay. See, for this na, you're telling this.
Yeah.
So the question
Correct.
is with this. So for
Yeah.
PDR-TB, I told ethambutol mein to we cannot check resistance at all. So ethambutol
Correct.
you are going to use. For pyrazinamide and this, I just explained. This is the thing. If Leoflox cannot be used, you may replace with moxiflox. If that also cannot be used, you replace with linezolid and clofazimine. Okay. Okay. So if Z also cannot be used, then you have to change. Obviously, if Z is resistance or there is intolerance to the pyrazinamide, you have to replace it with other drugs. It is not like even if it is resistant to Z, you will use it. So PDR is not a single, it does not pertain to a single group of patients. It will be like INH plus, I just told this, INH plus either E or Z. And for E, you cannot detect. So it is almost out. I would say it is out. So for PDR-TB, if patient is having resistance to INH plus Z, in that case, you have to modify this and you have to change this regimen. You have to use linezolid in place of pyrazinamide. Okay. So you will not use pyrazinamide if it is resistant.